Hi, joining me today is Joe Moffa. Welcome to Expert Insights, Joe. Thanks for making time for me today.
Thank you.
Now, you are the Chief Administrative Officer for Perioperative and Procedural Services at HUP at Penn Medicine, University of Pennsylvania Health System.
Correct. And HUP stands for Hospital University of Penn.
Okay. That's a title as long as many people's job description. Did I get everything right?
Yep, you got it right. Correct.
Okay, good. So, Joe, let's start out by letting people know who you are and how you got to be where you are. So, tell us a little bit about your career journey and how you ended up where you are in this role at UPenn.
Sure. My career journey is kind of unique in the fact that I started my career right out of nursing school as a trauma ICU surgical intensive care nurse. And then I actually managed an ICU for a little while. Then I came down to Periop and managed the PACU for 7 years, but also the pre-op area, the waiting areas, and I also opened a brand new 23-hour observation unit at that time span. Then I went on to direct the Penn Medicine Transfer Center for all of the Penn Medicine entities, and then also the patient flow bed management for Hospital University of Penn Hub. And I did that for another probably 4 years before coming back to Periop as the chief administrator officer. And I've been back in Periop and in this position for the last 2 years. So I have a pretty broad range of experience within this hospital. I've been here 21 years and know pretty much the entire hospital and a lot of different geography and different areas of the hospital. Plus, I'm clinical too on top of it. So
Wow. So, that's a pretty wide range of experience within the same organization. There are probably very few people that have the depth of insight into that organization as you do at this point, with 21 years in. How would you describe your current role and responsibilities there?
This role was created for me. I'm not only doing administrative work, I almost act like a CAO, COO of Periop. Basically, when I got here, we restructured the perioperative services, and I have multiple directors reporting to me, including the perioperative EBS transport and our service partner director. I have another director who directs our IP here, our anesthesia techs, and also our rad techs. That person reports to me. Our director of supply chain reports to me. Also, our director of regulatory for Periop reports to me as well. And then also we have a director of patient flow for Periop and also IT that reports to me. So even though I'm administrative, I also act in operations. I'm pretty entwined with the operations and what takes place here within Periop. So it's pretty unique and probably more than just what an administration person would do. And I think my clinical background helps with that as well.
It sounds very demanding on the administrative side. I'm surprised that you have the bandwidth to accommodate the clinical work as well.
Yeah, it's somewhat demanding, but I build a great team. So as you grow and a lot of our directors are somewhat new to being directors. So as I grow them as leaders, I'm able to utilize them to kind of do some of that work as well. And then, we all work together as a team to get the job done, to take care of our patients in the best way possible.
When we spoke earlier, a few days ago, you mentioned a recent significant organizational change that has taken place at UPenn. Can you talk to us a little bit about that and share what that experience has been like and what the goals were for that reorganization and whether or not you've achieved them?
Yeah, I mean, within our own department went through change. So I got back here 2 years ago, and also my counterpart, who's the executive director of perioperative services, who is an anesthesiologist, we worked together. And he started 4 months before me. Now, we both have been at Penn. I've been here 21 years. I think he's been 19 years. He's been in periop the whole time. But we worked together to run perioperative service and to reorganize it. That was a change in itself because the former perioperative director was here probably over 40 years, maybe. So, that was a big change. And then we, also had some new leadership come in from our department alone. So in addition to that, we came off of teletracking Navicare and went full Epic for our patient flow module. That was the first large change that we had to make within Periop. In addition to dealing with COVID as well, we also opened an offsite instrument processing center, also for supplies as well. And then that was in February of 2020. We came off of Navicare or teletracking in December of 2019, and then we opened a brand new $1.4 billion pavilion, which is a brand new hospital, while still running the other hospital across the street, in November of 2021. And in addition, within Periop, we also absorbed EP and cath services and echo within our 6th floor of our ORs. And then we also absorbed the neuro IR and neuro endovascular as well within Periop. So we basically have 3 floors of ORs and open 47 brand new ORs over here. In addition, we also manage the ORs still across the street in our legacy ORs, which we still run probably about 5 to 6 ORs over there a day. Plus, we also manage outpatient endoscopy connected to the hospital here on the 4th floor of our Perlman Center, in addition to a surgery center with 8 beds, which is connected to the hospital well at Perlman, another 8 ORs as well. So we managed all that, moved into this new building, had to get used to it, and then also stock our cores. And we have a 3rd floor where we have supplies as well. And then we never stopped surgery, really. The only stoppage we made was on the Friday before we moved the first half of our ORs. We made our cardiac and neurosurgery, urge emerge, which that doesn't mean anything to them. They'll still put plenty of cases on. We basically moved our ORs in basically 2 weekends and basically never stopped surgery. And all that with the great resignation on top of COVID and everything else. So a lot of change. Not that change is bad, it's good, but it's a lot on everybody. We're starting to get settled finally.
That amount of change in that short period of time certainly must have been challenging to you and your team. How would you describe the culture that you have there in terms of its resiliency, its ability to adjust to such changes?
Penn in general always had a culture of resiliency, just because it's a very complex, complicated place to work, because we see, the sickest patients and most complicated OR cases of, like most academic medical centers, but probably one of the highest CMI and high acuity hospitals in the country. So we've always been resilient, but to do that and have to get used to a brand new environment, especially our ORs were always the same. We built on them over the years, but they've been there for about, I don't even know, 70 years. I don't know how long. And, for the staff that's been there for a long time to go into this large change, get used to the new geography, have to get used to a new case cart movement from the ISC opening or the offsite processing. And also, getting used to different cores. And not to mention, we also turned over a lot of our chairs, which is unusual too at Penn. A lot of people stay here a long time. So we have a new chair of neurosurgery, a new chair of neuroendovascular, a new chair of ENT, a new chair of vascular, also a new chair of OFMS. I can go on and on. We have multiple new chairs, so that equals new surgical procedures, and they also bring a different experience and different doctors on board with them as well. So that was pretty large change as well. So a challenge, but we're doing well and starting to grow as we keep moving on.
So as the dust settles, presumably you're at the tail end of these changes and ready for a little bit more stability, I suppose. But are there remaining challenges that you're focused on? Are there things that are still keeping you up at night?
Well, we're still in the process of other changes as well. For instance, we're opening up a brand new Gift of Life donor center, which is probably maybe only the second or third of a kind in the nation. Basically, Gift of Life is going to partner with us, and they're going to utilize 3 of our older ORs, and patients that unfortunately are pronounced brain dead at outside hospitals are going to utilize a ICU we used to utilize here. And then when it's time to harvest the organs, they will come down to our 3 ORs that are dedicated to them, and we are partnering with them as well. We also are in the process of opening an ex vivo for lung in one of our ORs, and then also possibly an islet cell lab in one of our ORs. So a lot of big change there. We're also in the middle of renovating our Dulles OR for an endoscopy project. We're just waiting on a project manager to complete that. We also opened Radnor, which is under our HUP license, and we have a dotted line to them, Outpatient Surgery Center, which we work closely with them. And then we're also going to have to most likely move additional services back to our older OR, probably coming in the October, January 2023 timeframe, because we have to open more ORs for additional surgeons coming and other reasons as well. So a lot of movement and still a lot of change still to come going forward.
What do you think your biggest operational improvement opportunities are right now?
Biggest operational improvement. So we've been working on efficiency. Our first case starts have gone from when I first got here and John came on board, from about 14%, we're up to about 71% in-room first case starts, which is probably one of the highest probably in the country. And for an academic medical center, definitely at top tier. We're also working on our turnover in between cases. We're in the 50-minute range. We want to get that down to 45 minutes, sometimes or higher for our cardiac cases in the 60-minute turnover range, but we want to decrease that as well. We want to improve our preference cards, which helps improve efficiency. So we're working with Pref Connect for that. And then that also helps with our turnover. And then we're also would like to improve our overall incision time as well. So it's not just getting into the OR in time, which we're doing pretty well right now. We're actually doing real well, but we also want to get the case started, because you want to get the case moving along, and then the turnover between those cases you want to improve upon as well. So on top of that, we created a nice equation to show that we need to open more ORs, because I think we were landlocked over there. In addition to more change, we're opening, and the reason for having to probably move some services over to the other side again, we're opening 2 ORs, additional ORs in October, and we would open them sooner if we had the staff, but we have to hire. And another 2 additional ORs in January of 2023, and probably another EP lab. Another OR that we opened recently is a Rad Onc OR, which is in a different location on top of that, and we're going to expand those days. And then we're also going to open an additional EP lab in the October-January timeframe, which is most likely going to lead to us in January of 2023 to open 4 more additional ORs as well,
Wow.
to make everything fit and get everything done in a timely manner, because we want to make sure that not only are we completing our volume of cases, but we want to complete them in a timely fashion, so our staff has a good quality of life and work-life balance, so we don't lose more staff to, I don't want to say easier jobs, but yes, definitely more less challenging jobs outside of our organization, surgery centers and places like that.
I want to talk a little bit about the subject of staffing, because it's obviously a big issue at hospitals nationwide.
Mm-hmm.
What's your take on it? What challenges have you seen, and how are you positioning UPenn to compete for top-level staff?
Yeah, so I mean, a lot of the movement has to do with money and work-life balance, like we just talked about. So in terms of the money, we did give increases to make sure we're always competitive. We were always competitive, but of course that has increased over time. But we also are creating a lot of incentives for people to stay as well within Penn and different areas within Penn. So that's a key opportunity as well. And then the second part is what I covered already, because this is a very challenging place to work, because we're very complex. Sometimes people don't want that anymore, to work at, the most challenging places that's interesting and you'll learn something new every day. Ever since COVID, a lot of people just want less challenge and just be able to go home in a timely fashion. So that's why we want to open these additional ORs, to make sure that our staff, all of our staff, have a better work-life balance in which they can work, their normal regular hours, but also work those hours in the daytime and be able to go home to their families and things like that. You're always going to have a night shift, but you don't want to decrease the amount of people that have to work.
Right.
They're the challenges we're facing, and they're some of the things we're trying to do to help improve staff engagement and also happiness overall.
Now, a few minutes ago, you mentioned preference card management, how you'd recently implemented the Pref Connect system. I'd like to hear from you about the link between patient outcome and patient experience and better management of preference cards.
Preference cards really drive how the case is picked for the day. So first, thing you want to solve is you want to make sure the case is scheduled correctly. So, we have people behind the scenes that check the case scheduling. We check also for the necessary elements to get into the OR, which we would call a clean chart check, meaning that you have an H&P up to date, you have a H&P update, you have a VTE order. These are all regulatory reasons, a consent. You got to make sure all this stuff is done to get into the OR on time. So we check that ahead of time. But then you also want to make sure that the case is scheduled correctly from a CPT code standpoint. So that means those CPT codes drive what is picked for the case. And if the case is not picked correctly, then what that causes is delays in turning over cases, delays in getting patients into the OR, which then delays patients when they get here. They're sitting around and waiting. It could even lead to canceled cases. That doesn't happen often here, but it can lead to that. And that's the worst case scenario, that a patient takes off from work, which they may not have a lot of time. They get a ride, someone else takes off from work, and then you have to cancel a case. That's a really bad situation. But you also don't want to delay cases, or the patient comes in, let's say they arrive at 10 for 11 o'clock or 12 o'clock case, and they're getting the OR until 1, 2 p.m. They're sitting around waiting, and that's bad for patient satisfaction. So the preference cards drive all that and the efficiency overall, because if everything that's on the preference card is in the case card or in the room once we clean the room, then, we can get the next patient in quicker. And the turnover, it's a redundant or repetitive movement throughout the day to keep doing that. All those things drive patient satisfaction and overall within the day. So that's why we want to do that. We have already made great improvement with cleaning our rooms. We're basically cleaning our rooms in about 15 to 22 minutes, which is probably the best you can do. It's just that sometimes we don't get into our rooms for another 20 to 30 minutes. And that's where that improvement needs to be made. And some of that improvement is the preference card. The great thing about the Pref Connect is not only do they tell us what is on the preference cards that we can take off to save money, but also they could tell us what's not on there that we're documenting that needs to be put on the preference card for the efficiency part overall. And in addition, the Pref Connect team will make those changes with our approval, and we don't have to use clinical staff that need to be in the OR, especially in this time frame, to do that for us. So that's the beauty of it overall.
So you have both the improvement in patient care, the speed into the OR, et cetera, but you also have this waste reduction factor that you have going for it as well. On the waste reduction, are there ways that occurs that are not apparent? Anything that you've discovered about it once you implemented it?
Yes. So a fine example of it, our former leadership that was here prior to us tried to standardize our preference cards between our services, our service line leaders, but the issue was they were still allowing them to purchase a lot of supplies, and they weren't standardizing how they were doing the cases. So if you're not going to standardize, which we're not, then you have to create more individualized service or attending preference cards, or surgeon driven. So a fine example is you have a thoracic surgeon. One thoracic surgeon uses 20 of one item, but the other one doesn't. Well, if you use a standardized preference card, the person that does it is going to get these 20 items picked, possibly opened and wasted, right? And the other one is going to use it, but the other one isn't. So what the Pref Connect shows us is who's doing it, who's not. We pull that off the individualized preference card for that other surgeon, and then it's only getting picked for the surgeon that's using it. So not only is it a savings, but it's saving on both the cost of picking it, but also the labor that has to pick it as well. And then what could possibly get wasted in the room because someone could have opened those supplies. We also work to look at opening versus non-opening as well with the Pref Connect, that we can put so the certain things that maybe they might use, PRN we call it, or when necessary, we're being open, but now we have them not being open as just, picked, but not opened on the field where it would be wasted at another time, wasted in the case. So that's another opportunity, but that's an example of what we've been doing to help save money, but make a more individualized preference cards, which is very key right now with all our new surgeons, with new techniques and everything else overall.
Now, with legacy preference card management systems at most hospitals, there's often a lack of reliable or current data upon which to base decisions on which solutions to employ. How did you evaluate or come to understand an ROI on employing a system like PrefConnect at UPenn? Did you have good data coming in, or what was your situation prior to implementing PrefConnect?
So we have some good data. I think what really drove us is we opened the offsite instrument processing center, which is not just picking instruments for us, it's also picking supplies. So if our preference cards aren't correct, you're going to have a lot going back and forth in case cards of unused supplies. We were finding basically 20 or so case cards of unused supplies going back and forth between us and our offsite processing center. So we really needed to decrease that delta, mainly because we don't have the clinical staff right now to be updating these preference cards and checking them. So along that correlation with the new surgeons, our preference cards were just very poorly done at this time. They're just not accurate or poorly inaccurate. That's what really drove us to have to do this. And we just didn't have the clinical staff to do it as well. So what was interesting is we use an electronic app, which actually allows us to pick our cases, both at the ISC and at our entity. And what we did was we married that with our loss and cost prices so we can see what is actually picked from the electronic app from a total cost perspective. And then we can see the delta from what was actually documented within the Epic system. That's an Epic report we can pull. And we can see the delta of how much is not being used or being wasted or sent back. And then we also married that with what is being pulled out from PrefConnect to see as we do move through our services with PrefConnect to decrease the supplies or remove supplies, if that delta starts to minus. So let's say that delta is 200,000 a month. Each month is that delta getting smaller and smaller. You're never going to eliminate the delta because you have to put certain CPT codes on a case of what you might do, because that's just how you get reimbursed from the insurance, but you charge for what you actually did do. But we wanted that delta to keep decreasing, which it is at the moment, and we're going to continue to monitor as we keep moving on our services within PrefConnect.
The common factor that I'm hearing here is access to good data and good analytics helps drive greater efficiency. Are there areas in your practice, aside from preference cards, where you see an opportunity for AI or for some data-driven technology to help that you haven't implemented yet? Are there things you're looking for in the future that you say, oh, if somebody would come up with a way of doing this, that would be huge?
Yeah, that's a tough question. I mean, we use a system called Census for our case cards and our instrument processing, but the issue with Census is it's very geared towards just instruments processing. And we've met with them many times, is they need to not make it just geared towards instrument processing, but the whole perioperative diet as a whole. So how the instruments go into case cards, go to cases, and being able to track all that. So they're working on that, but that's technology that needs to be grown. The issue with the technologies overall that I've seen is they have to have the ability to adjust to your algorithm. So they got to be smart enough to get in the weeds, I would say, of what's going on within each different hospital's system. So sometimes these technologies are grown to just basically be out of the package cover basics, but they aren't able to adapt to different ways that people do things. And that's what's important, being able to create those algorithms to say, if X, then Y, or then Y, then Z. And a lot of them can only do X, A to B. They can't go C to D or E to F. So right. That's the problem with a lot of these technologies. So there is opportunity in many areas for anything from just efficiency and turnover and your IP and your offsite processes. And it's the act of putting it all together and being able to integrate those algorithms to what you're doing in your hospital system, not just here, Penn, but if you're in some other hospital system or even other, and we own about 6 or 7 different hospitals, the other hospitals as well, because even though we're the same Penn system, we can't be completely standardized due to the complexity of each hospital and what they do.
Yeah, and I would assume some of that inability to be completely standardized and consistent across all of your facilities has to do with the legacy systems that they brought into place. I mean, because organizations grow by acquisition as well as organically. So, you acquire a facility and they already have systems in place. You have to figure out how to integrate that.
Correct. Yeah, a fine example is we did something I would call an Epic Sprint project in my former position in bed management and transfer center, in which when we went live with Epic, we were in the dark in terms of patient movement and capacity management. When we met with their CEO over at Epic, we actually went to Wisconsin, so our leadership, myself when I was in my old position with our CEO and CEO, Epic didn't realize that capacity management was an issue in hospitals. And we explained it to them, and they actually grown to have their own capacity management arm, or whatever you want to call it, within their system. And they learned to adapt and make it, and we created a lot of different ways, and both from just patient movement and boards and transparency throughout the whole health system within Penn for Epic, because it just wasn't where we needed to be. Now they're not perfect. Some of their algorithms just can't be created, but we got it to a place where, it's very manageable and could tell us and what's going on. We could see what's going on, which we didn't have any of that when we went live. And it's the same thing with PERIOP. When you get new systems, they have to be able to adapt to where you're at and what you're doing.
Well, as we wrap up here, and thank you for your time today, just tell me what's on your wish list. What are you hoping for that would make your job easier, more effective as we go forward?
Unfortunately, the number one thing is to get staff in here as fast as possible. We're, of course, we got financial approval to hire, but we can't hire quick enough. And then also maintaining staff, and then also getting staff trained so we can, open our additional ORs. All that stuff takes strain off the current staff and less overtime for that staff and everything else. So getting staff on board is probably number one right now. And then continue to grow our technologies and improve our efficiency, which will also help maintain staff. It all grows together to maintain a better life-work balance for our staff going forward. So, that with creating that healthy work environment with our staff and getting them on board, which all those systems that we just talked about help improve that from a day-to-day standpoint, is probably what we want to do and our main goal right now. And then also get all our other projects completed and hopefully continue to grow as a health system.
Once again, Joe, thank you so much for your time today. Appreciate you taking a few minutes out of your busy day to talk to us.